Today's topic is bronchiolitis. Infants are more likely to have wheeze than older. Now, first of all, let us see the differential diagnosis of the wheeze. Why infant wheeze more than the older? It is related to the airway caliber and the compliance. Talking about the airway caliber, the total airway resistance in infant is more. And talking about the compliance, the newborn chest wall is very compliant. During expiration, it tends to collapse. And another factor for the infant, they wheeze more are difference in tracheal cartilage composition and smooth muscle. As we know that resistance is inversely proportional to the fourth power of radius. So a small reduction in radius of the airway increases the resistance by 4 times. We can remember differential diagnosis of wheezing in infant by the mnemonics IMS. Let us read this others in next part. I am others as. I means infection, M means anatomical defect, others means others. Let us study later on. S means as asthma, aspiration. Now, first of all, let us learn about the infection. In infection, viral infection. In pneumonia and in bronchiolitis, the causative viral organism is same. RSV, enterovirus, adenovirus, influenza, parainfluenza virus. Human metapneumovirus and Boca virus are the emerging virus that cause bronchiolitis. Now, anatomical abnormality. In anatomical abnormality, central airway abnormality, extrinsic, intrinsic airway abnormality, central and extrinsic and intrinsic airway abnormality. Now, in aspiration syndrome, GERD, gastroesophageal reflux disease, and pharyngeal swallow dysfunction. Now, in case of asthma, also the child wheeze. There is 3 types: transient wheezer, continuous wheezer, and late onset wheezer. Transient wheezer are the children in which wheeze resolved within 6 years. In continuous wheezer, children wheeze for more than 6 years. In late onset wheezer, the wheezing begins after 3 years and it persists. Now, other cause of wheezing in infant are bronchopulmonary dysplasia, interstitial lung disease, inhalational injury, heart failure, and anaphylaxis. We can remember with the mnemonics BIHA, BIHA. Here is one point. In bronchoalveolar lavage, in infant, we can see more lymphocyte, neutrophil, histamine, interleukin, leukotrienes, while in adults, we can see mast cell and eosinophil. Now, our topic is bronchiolitis, and we are gonna study risk factor for bronchiolitis. In previous lecture of pneumonia, the same mnemonics is used for risk factor, that is no any risk factor. No means nutrition, any means air pollution, RIX means recurrent respiratory tract infection in family, factor means family. Now let us see on nutrition. No breastfeeding, malnutrition, vitamin A deficiency, low birth weight, prematurity, congenital heart disease or CLD. Now in air pollution, what can be other pollution? Second-hand smoking, mother smoke during pregnancy. Now RIX means RTI in family members. Now in family, what can be in other factor in family? The large family, overcrowding. For pneumonia, there was different organism for different age group, but in bronchiolitis occurs within age group 1 month to 6 months, but it can also occur up to 2 years. Peak occurs in 6 months. It occurs mainly during winter and spring. It occurs more in male, and organism 50% of bronchiolitis is caused by RSV, and human metapneumovirus and Boca virus are the emerging virus causing bronchiolitis. Talking about the immunity for the bronchiolitis, there are 2 immunity, IgG3 and IgA. IgG3 are present in the mother during pregnancy, but it doesn't cross the placenta, so it is not available for the infant. but IgA antibody is present in the colostrum. So through the breastfeeding, IgA antibody travels into the infant. So breastfeeding can prevent the bronchiolitis. Now let us talk about the pathogenesis of bronchiolitis. Respiratory syncytial virus acts on the epithelium of the bronchioles. After that, inflammation occurs and exudate formation occur. Through the exudate, cell debris and mucus plugs occur. As mucus plug is in the airway passes, the narrowing of the bronchial lumen occur, and during expiration, bronchial tend to collapse. Either there is partial obstruction or there is complete obstruction. If there is partial obstruction, the trapping of the air occur, and it is like the emphysematous change. If there is complete obstruction, the trapped air is absorbed in the lungs, so the feature of the atelectasis can be seen. Finally, the respiratory failure occur. There is hypoxemia and respiratory acidosis. Now, to diagnose the bronchiolitis, first of all, history and physical examination. We can ask about the birth history, malnutrition, low birth weight, vitamin A, prematurity, chronic congenital heart disease, chronic lung disease, lack of breastfeeding, smoke exposure during prenatal time, recurrent infection, respiratory tract infection in family history for cystic fibrosis, asthma, social history, smoker or TB. In history, we can ask about the different risk factor. Now, examination. In examination, most of the bronchiolitis can be diagnosed through the clinically. Prodromal symptoms like contact with older adult with upper respiratory tract infection, the patient present with sneeze, rhinorrhea, loss of appetite. Then the symptoms progresses, appearance of fever 101 to 102 degrees Celsius Fahrenheit, that is low grade fever. Then the cough appears, wheeze, dyspnea, fast breathing. For less than 2 months, apnea is more pronounced than wheezing. It recovers within 3 to 7 days. Now in inspection, we can see chest indrawing, supraesternal nose indrawing, use of accessory muscle for respiration. In percussion, we can see a hyperresonant due to the hyperinflation of the lungs. In auscultation, fine crepitation and bronchi can be seen. Like in pneumonia, we will send for the CBC for diagnosis. CBC will appear normal as it is a viral infection. In chest X-ray, hyperinflation or patchy collapse of the lung is present, and liver spleen is pushed below due to hyperinflated lungs. Virus can be diagnosed through PCR, rapid immunofluorescence test in nasopharyngeal aspirate. What is criteria for hospital? If the infant present with a respiratory distress syndrome, then the infant is hospitalized. The supportive treatment is given. No antibiotic is given for bronchiolitis. Saline infusion to balance the fluid and electrolyte, and antibiotics to control the fever. The patient is kept on 30 to 40 degree reclining position. If there is severe hypoxia, tracheal intubation is done. Suctioning of secretion is also done. Continuous positive airway pressure or assisted ventilation or extracorporeal membrane oxygen is effective. Antibiotics is not given in case of bronchiolitis. Bronchodilator is given. Corticosteroid is not given for previously healthy child. Ribavirin is given if the child is present with congenital heart disease, chronic lung disease and bronchiolitis. So how can we prevent? By administering the pool hyperimmune respiratory syncytial virus, intravenous immunoglobulin or palivizumab, that is respiratory syncytial virus F protein antibody.